It's 8 a.m. We are in the operating theater section 1. A team is preparing to perform a scheduled Caesarian section. Sasha, a 36-year-old mother of 2, all alive and well, smiling and confident, just walked in the operating room assisted by staff. This will be the 3rd time she undergoes a Caesarian section, this surgical way of childbirth. The Caesarian section was scheduled 2 weeks ago during her antenatal clinic. The Caesarian section was indicated for the history of 2 previous Caesarian section deliveries. Sasha came in and was admitted yesterday. Since her admission, she has been seen and examined by her surgeons, anesthetists, and nurses for the safety of the operation. It's been confirmed that it was the appropriate time for her to safely deliver a baby. Allergies to various medications were ruled out as well. She has also been informed about possible complications of such an operation, and she signed the consent based on all the information she received. Blood tests have been performed as well. For about 6 hours now, Sasha has been recommended not to eat nor drink. Intravenous through which she will be receiving fluid and medications were placed as well. Urine catheter were placed too. Sasha is informed that it's time for her to receive the anesthesia she opted for. On the other side of the operating table, the anesthetist and his assistants have prepared various drugs that constitute anesthesia. Within few minutes, the anesthetist will be checking if the anesthesia has worked and then allow the surgeon to perform the Caesarian section surgery. A Caesarian section, also called a C-section, is the surgical delivery of a baby through surgical cut or incisions made in the mother's abdomen and the uterus. How the Caesarian section is performed? After the incision is given, the skin is cleaned several times with 1 or multiple antiseptic solutions that are used to kill and destroy different germs and impurities found on the skin that can infect the surgical wound. One solution most surgeons use to clean the skin before Caesarian delivery is the povidone iodine. After the skin is cleaned, the abdomen will be covered or draped. Then comes the time for the proper Caesarian section or surgery. To achieve a C-section delivery, the surgeon must cross all the layers that separate him from the fetus. These layers are the skin, the subcutaneous tissue, the fascia, muscles, the peritoneum, and the uterine wall and membrane that surround the baby. Depending on countries and institutions, there are many approaches and techniques for surgeons to open each of the layers that separate the surgeon from the fetus. Step 1. Opening the abdominal wall. This act of opening the abdominal wall is surgically called as laparotomy or recently an abdominotomy. This can be done either by the fenestrial incision, whereby a sharp skin incision is made in the skin at the lower abdomen 2 cm above the pubic bone. The subcutaneous adipose tissue and the abdominal fascia are also sharply cut and the aponeurosis of abdominal muscles is detached. The rectus abdominis muscles are then pushed apart, followed by the incision of the peritoneum. Possible incision to open the abdominal wall skin during a C-section are the midline skin incision, the extended midline skin incision, the joint coin skin incision, and other incidental skin incisions such as the infraumbilical transverse incision and the supraumbilical skin incision. Step 2. Opening the uterus. This act of opening the uterus is called by itself a hysterotomy or recently a uterotomy. There are different ways to open the uterus. The most common are the lower transverse uterine incision, the lower transverse incision with a U extension, the lower transverse with J extension, the lower transverse with T extension, the midline, the high transverse incision, the midline vertical incision, also called the classic or classical incision, the lower vertical uterine incision, the fundal midline incision, and the fundal transverse incision. Step 3. Rupturing membranes. While rupturing membranes, the amniotic fluid is released, for which the surgeon will assess the color, the smell, and the amount. The normal color for amniotic fluid is clear with small whitish veinous particles with no odor. Amniotic fluid that looks green or brown means that the baby has passed the first bowel movement or the meconium while in the uterus. This may be a sign of fear or distress, for which we'll talk about soon. The foul-smelling amniotic fluid means there might be an infection of the uterus, also called chorioamnionitis. The normal amount of amniotic fluid is about 600 cc at 39 weeks pregnancy, when a scheduled Caesarian section delivery is usually done. Too much amniotic fluid is called polyhydramnios, and too little amniotic fluid is called oligohydramnios. Step 4. Extraction of the baby. After rupturing membranes, your surgeon will confirm which part of the fetus present first and proceed to an extraction. The easiest presentation to be extracted is the head-down presentation, also called cephalic presentation. Step 5. Umbilical cord extermination, clamping, and cutting. Once the baby is extracted, the cord will be examined, then clamped. Recommendations are to wait up to 1 to 3 minutes before clamping the cord. This is called delayed umbilical cord clamping. This allows the blood in the cord and the placenta to flow to the baby. This improves the neonate circulation and prevents neonate anemia. Some contraindications for the delayed cord clamping include the mother having rhesus negative blood group, the mother having an infection such as HIV infection, and the baby requiring immediate innervation or resuscitation. After cutting the umbilical cord, blood sample can be collected if necessary. Step 6. Removal of the placenta. This can be done by controlled contraction and fundal massage or via manual removal. Due to data showing a reduction in operative blood loss and a decrease in blood loss if spontaneous placental delivery, this is the chosen option with controlled umbilical cord traction and fundal massage, and this technique is preferable if the clinical scenario allows. After delivering the placenta, the uterus is cleaned with moist peritoneum sponges or abdominal packs. Step 7. Uterine closure. For the repair itself, a delayed absorbable suture is used in a running fashion. A running closure decreases the blood loss and operating time compared to interrupted closure. The closure of the uterus in 1 or 2 layers have been investigated. For women desiring a future trial of labor, there is evidence showing an improved residual myometrial thickness and scar healing and a decreased risk for uterine rupture in subsequent pregnancies if utilizing a 2 layers closure. An unlocked closure technique may also be preferable to the locked technique. Once the uterus is closed and hemostasis assured, the pouch of Douglas or posterior cul-de-sac is cleared of blood and clot using peritoneum sponges and suction. Intra-abdominal irrigation before closure has been shown to increase nausea during surgery and did not improve the return of gastrointestinal function nor incidence of infection. Step 8. Abdominal wall closure. Closure of the peritoneum adds operative time and it may increase post-operative fever and length of hospital stay. Before closure of the fascia, the rectus muscles and subfascial tissues are inspected to ensure hemostasis. The rectus muscles can be reapproximated in advance of fascial closure. Some surgeons believe that suturing the muscles reduces the risk of subsequent diastasis recti and decreases the incidence of the intra-abdominal adhesions formation. Conversely, reapproximating the muscles leads to increased postoperative pain. Given time, the surgeon could involve the patient in sharing decision-making regarding this technique. The fascia is then closed using a delayed absorbable suture in a running and unlocking fashion. Historically, the fascia has been closed by some in an interrupted fashion, but this technique is no longer used. Using a monofilament rather than a braided suture may decrease the risk of infection and should be considered in patients at higher risk of developing these complications. Monofilament suture may also decrease the risk of subsequent hernia formation. The subcutaneous tissue are then irrigated and hemostasis is assured. Interestingly, wound irrigation has not shown to decrease the infection rate. However, it may also help to visualize an area requiring additional hemostasis. Closure of the subcutaneous space is recommended if its thickness is 2 cm or more. This decreases the risk of hematoma, seroma, wound infection, and wound adhesions. On the other hand, grain placement in the subcutaneous space is now a recommendation. Skin closure may be achieved using a variety of methods, the most common being subcuticular suture. There is also an increasing use of surgical adhesive glues and subcutaneous absorbable staples. Research has shown both subcutaneous sutures and staples to be similar with regard to cosmesis, but data revealed subcutaneous suture to be superior to staples regarding wound separation and wound infection. Again, monofilament provided less risk of infection than braided suture. At different steps, safety measures applied by surgeon and assistant consist of hemorrhage and infection prevention and counting needles, sponges, and instruments before the operation and after closing each cavity. After the closure of the skin is done, a dressing is placed. The following is the summary of the 4 standard Caesarian section operative techniques. How long does a C-section surgery take? The surgery takes 30 minutes to an hour with an average of 45 minutes. The baby is usually extracted within the first 5 to 10 minutes. And the rest of the time is dedicated to the uterus and abdominal wall repairs. After the operation, you'll be taken to the recovery room where you'll stay for a period defined by your surgeon, usually 4 to 6 hours. In the recovery room, you'll be assessed every 15 to 30 minutes for possible hemorrhage or bleeding. Your blood pressure, heart rate, respiratory rate, and temperature will be checked. The neonate vital sign will be assessed as well. Initial breastfeeding, uterine evolution, urine output, and bleeding will be assessed as well. It will be recommended to you not to eat nor drink for some hours, but you'll be given medication and fluid through an intravenous. You'll be asked to immediately breastfeed for about 30 minutes and to repeat breastfeeding every 2 hours. We recommend you to watch videos on breastfeeding on this channel for more information. After 4-6 hours, they will allow you to eat, drink, and you'll be helped to move and walk around. But not that. The first 24 hours after C-section are particularly a very critical period, especially for postpartum hemorrhage. It's carried by a Caesarean section. Like other types of major surgeries, Caesarean sections carry risk. Risks to the baby include: number 1, breathing problems. Babies born by scheduled C-section are more likely to develop a breathing problem than those born normally. 2, surgical injuries. Although rare, accidental nicks to the baby's skin can occur during surgery. Risk to mothers include: 1, reaction to anesthesia. Reactions to any type of anesthesia are possible. 2, surgical injury. Although rare, surgical injuries to the bladder or bowel can occur during a Caesarean section. 3, excessive blood loss. C-section might cause heavy bleeding during and after delivery. 4, infection. After C-section, there might be a risk of developing an infection of the lining of the uterus, in the urinary tract, and at the site of the incision. Number 5, blood clot. C-section might increase the risk of developing a blood clot inside the deep vein, especially in the legs or pelvis. This is called deep venous thrombosis. If a blood clot travels to the lungs and blocks blood flow, this is called pulmonary embolism, and the damage can be life-threatening. Number 6, increased risk in future pregnancies. Having a C-section increases the risk of complication in later pregnancies and in other surgeries. The more C-sections, the higher the risk of placenta previa and morbid placental adherence such as placenta accreta, increta, and pecreta. A C-section also increases the risk of the uterus tearing along the skull line for women who attempt a vaginal delivery in later pregnancies. What can you expect before and after a C-section? Before the procedure, if a C-section can be done in various ways, most C-sections involve these steps. At home, your healthcare provider might ask you to shower at home with an antiseptic soap the night before and the morning of your C-section. Don't shave your pubic hair within 24 hours of your C-section. This can increase the risk of surgical site infection. If your pubic hair needs to be removed, it will be trimmed by the surgical staff just before surgery. At the hospital, your abdomen will be cleaned and a thin tube catheter will likely be placed into your bladder to collect urine. An intravenous line will be placed in a vein in your hand or arm to provide fluid and drugs, including antibiotics, to prevent infection. Anesthesia. Most C-sections are done under regional anesthesia, which numbs only the lower part of your body. This allows you to be awake during the procedure. Common choices include a spinal block and an epidural block, but some C-sections might require general anesthesia. With general anesthesia, we won't be awake during the birth. after the procedure. A C-section usually requires a hospital stay for 2 to 3 days. Your healthcare provider will discuss pain relief options with you. Once the anesthesia begins to wear off, you'll be encouraged to drink fluids and walk. This helps prevent constipation and deep venous thrombosis. Your healthcare team will monitor your incision for signs of infection. The bladder catheter will likely be removed as soon as possible. You can start breastfeeding as soon as you are ready. Ask your nurse or a lactation consultant to teach you how to position yourself and support your baby so that you are comfortable. Your team will select medications for your surgical pain with breastfeeding in mind. And when you go home, during the C-section recovery process, discomfort and fatigue are common. To promote healing, take it easy. Rest when possible. Try to keep everything that you and your baby need within reach. For the first few weeks, don't lift more than 10 kgs. Use recommended pain relief. Your healthcare provider might recommend a heating pad and pain medication that are safe for breastfeeding women and their babies. These include ibuprofen and paracetamol. Check your C-section incision for signs of infection. Pay attention to any symptoms and connect with your healthcare provider if your incision is red, swollen, or leaking discharges. If you have fever, if you have heavy bleeding, if you have worsening pain, if you have severe mood swings, loss of appetite, overwhelming fatigue, and lack of joy shortly after childbirth, you might have postpartum depression. Connect with healthcare provider if you think you might be depressed, especially if your symptoms don't go away. If you have trouble taking care of your baby, or if you have thought of harming yourself or your baby. Connect with your healthcare provider if you think you might be depressed, especially if your symptoms don't go away. And within 12 weeks after delivery, see your healthcare provider for a postpartum evaluation. During this appointment, your healthcare provider likely will check your mood and emotional well-being. Review information about infant care and feeding, talk about your sleep habits and issues related to fatigue, and do a physical exam, including a pap smear if it's due. This might include a check of your abdomen, birth canal, cervix, and uterus to make sure you are healing well. Why a Caesarian section is performed? The following are indications for a Caesarian section. We have maternal indications, anatomical indications, and fetal indications. Maternal indications for Caesarian section are prior Caesarian delivery, 2. Cephalopelvic disproportion, 3. Previous perineal trauma, 4. Previous pelvic reconstructive surgery, 5. Herpes simplex or HIV infection, 6. Cardiac or pulmonary disease, 7. Cerebral aneurysm, 8. Arteriovenous malformation, condition requiring concurrent abdominal surgery, 10. Perimortem Caesarian section and Caesarian section on requests. Anatomic indications for Caesarian section include genital obstructive mass, permanent cervical cyclage, invasive cervical cancer, 4. Prior full thickness myomectomy, 5. Prior classical hysterectomy, 6. Placenta abruptio, and so on. Fetal indication for Caesarian section comprises fetal distress, including abnormal umbilical cord Doppler study. 2. Umbilical cord prolapse. 3. Malpresentation such as breech presentation, transverse lie, etc. 4. Congenital fetal anomaly. 5. Big baby, usually a baby with 4.5 kgs. 6. Prior neonatal birth trauma. 7. Failed operative vaginal delivery. 8. Multiple pregnancies. Contraindications for Caesarian section. There is no absolute contraindication for a Caesarian section, but a C-section is an option if the pregnant woman is dead or dying, or if the fetus is dead. While there are ideal conditions for a Caesarian section, such as the availability of anesthesia and antibiotics and appropriate equipment, the absence of these is now a contraindication if the clinical scenario dictates. But ethically speaking, a C-section is not an option if the patient refuses. So adequate education and counseling are crucial for informed consent. However, if the pregnant patient does not consent to have a surgery performed upon her body, ultimately it's her right as an autonomous patient. There are also some clinical scenarios where the C-section may not be the preferred option, and one could consider these relative contraindications. For example, a pregnant patient may have severe bleeding disorder, which makes surgery extremely dangerous. In that case, vaginal delivery may be preferable. And in the event of fetal demise, performing a hysterectomy exposes the pregnant patient to the risk of scars without enjoying any fetal benefit. The same considerations apply if the fetus has severe anomalies that are incompatible with life. Equipment. The equipment required for a Caesarian section varies depending on the clinical scenario. At the most basic level, the only thing is some cutting instruments. In an emergency, for instance, a doctor could, in theory, perform a perimortem Caesarian delivery on a woman after a car accident with a sharp piece of glass. Normally, that is just theory. Luckily, such emergency scenarios are very rare, but they do happen. Various consumable and usable items are used to make a Caesarian section safer for the mother and the fetus. Again, the clinical scenario dictates the equipment used. Many hospitals have standardized surgical packs specific to Caesarian deliveries. These packs contain the necessary drapes, surgical towels, etc. They may also contain bulb suction, umbilical cord clamps, suction tubing, or other consumables specific to a Caesarian section. At the head of surgical table is the anesthesia equipment, which includes monitors for patients' vitals, organizational cabinet, medication for achieving adequate anesthesia, and airway equipment. The Caesarian instrument tray includes several kinds of scissors, clamps, forceps and retractors, needle drivers, and many other instruments. Availability of standardized surgical pack and instrument tray is beneficial. For instance, if an emergency Caesarian section is needed, this will mitigate the time-consuming need to gather appropriate equipment. Having the appropriate instrument readily accessible can save precious time in an emergency. I am Dr. Eric. This channel delivers information that promotes health and holistic wellness. All the information provided on the channel is tailored for holistic comprehensive medical education.
Wow!
If not subscribed yet, subscribe now and click on the notification so that you don't miss any content. Thank you for watching. See you soon.